Hello. Hope everybody's doing well. My name is Michelle Smith, and I am a senior manager with the Orange County Healthcare Agency, Behavioral Health Services. And I would like to thank you for joining us, or me, to go ahead and listen to and receive about an overview of our MHSA plan for fiscal year 24-25. I'm going to go ahead and share my screen. There we go. Hopefully everybody can see that screen okay. So we have a draft that is posted of our Mental Health Services Act, or MHSA, annual update for fiscal year 24-25. It is posted on our HCA website. I will include that link at the end of this presentation. But before we get started, I just wanted to give you a little bit of an overview. Of course, this is a recording, so there's not going to be any discussion. So in terms of the agenda, just going to give you a little bit about the MHSA basics. We're going to talk a little bit about Proposition 1, because Proposition 1 plays a potentially significant part in future MHSA plans, as well as behavioral health services at the county level. And then I'm going to talk a little bit by each of the MHSA components, what those updates are, and then kind of give you an update of the timeline and our next steps. So just to get us started, MHSA was voted on by California voters in November of 2004, and it became effective January 1st, 2005. What it does is it places a 1% tax surcharge on millionaires' income, and all the money is then collected at the state level and distributed to county behavioral health systems, or specialty mental health plans is like the technical word for it, across the state of California. The intention is really to expand the array of services that are available to our beneficiaries. Our primary beneficiaries in the county are those that are recipients of Medi-Cal or Medicaid services, and it helps to fill in the gaps for meeting the needs of those folks that go beyond what traditional health insurance would pay for, or Medi-Cal. So we really use MHSA to kind of develop a culturally competent system of care with priority on folks, especially in prevention and early intervention, on individuals that are unserved or underserved in our communities. Why do we do this plan? Well, it's part of the law. So every 3 years, we're required to create a 3-year plan that includes all of the different components of MHSA, which I'll review with you in just a moment. And then every year, because as community needs change, as things, funding might change, all of those things happen, we're go ahead and we do an annual update to that plan. We make that plan publicly available. And we also offer all kinds of opportunities while the plan is posted, such as now, for you to meet with us and to hear about any of the changes or updates or the services that are available, not just in the plan, but are available to our community, because every program in the plan equals the delivery of services to the folks that live in Orange County. Alrighty, so just some kind of basics. We're getting into a little bit of alphabet soup here. The majority of funding for MHSA is geared towards services and programs that are designed to serve individuals living with serious and persistent mental illness. And so CSS, or Community Services and Support, 76% of the funding goes towards those types of programs. So CSS services can a lot of times be combined with Medi-Cal so that we can generate revenue and offer more services to more people. It helps to pay for things like our crisis system of care. We do a combination of funding to make those services whole. So like mobile crisis assessment teams for individuals that might be experiencing a behavioral health condition. And we go to where you are to be able to help you manage that and hopefully create a plan with you to keep you safe and to keep you stable and help you out along the way. Also, recovery types of services, such as our wellness centers, are funded through CSS, as well as several other programs. So the second largest funding component under MHSA is prevention and early intervention, or PEI. So 90% of the funding goes there, and those services and programs are designed to do exactly how it sounds, to be able to prevent a behavioral health condition from becoming severe and disabling, to be able to intervene as early as possible when folks might be experiencing signs and symptoms, and then also to address risk factors. We know that there are, research has identified risk factors that could contribute to the development of behavioral health condition later on. And so we want to address those risk factors and build resiliency and keep people well right in the beginning. Also, being able to fund some community education and outreach so people can understand and know and recognize what those signs of, a behavioral health condition possibly could be. So as they're thinking about themselves or their loved ones, they might have a frame of reference. It's no different than any of the education you would receive for like a physical health condition, like signs and symptoms of, or risk factors for diabetes. It's the same thing, just for behavioral health. Then 5% of the funding really goes towards innovation or research types of projects. So we take a little bit of money from that CSS pot, a little bit of money from the PEI pot, and we combine it to be 5%. And it helps us to test approaches or processes that help improve the delivery of care or build in efficiencies, making things work smoother. Because the whole idea is to be able to build an integrated system of care that's easier for our communities and our clients to navigate. Also, there's two other components that are included in here, and we're allowed to take a little bit of that, about up to 20% of that CSS funds, and transfer it to these other two components. The first component I'll talk about is the workforce education and training component, and that really is kind of to help build our infrastructure. If we have all these programs and all of these services, we want to make sure that we have a really well-trained workforce to deliver those services. Not only that, but with healthcare, especially behavioral healthcare shortages nationwide, we want to make sure that we can invest in the recruitment, retention, and development of public behavioral health employees. And that also includes our contracted provider agencies. So we can put some money towards workforce education and training initiatives. There's also the capital, facilities, and technological needs component. And that really is just a fancy way of saying we need to be able to build space or revamp space so that we can deliver these services there. So it's really capital means, places. So if we need to have a building to be able to provide a program, then we could use some of the money for that. And then technological needs is really being able to make sure that we can build and sustain our systems for data analytics, so that we know if people are getting better and how they're getting better and all of that information, and then being able to do our billing through things like our electronic health record. So we can utilize some of the funding for that. All righty. The last component that I want to talk about is community program planning. It's part of what we're doing right now. We go through and meet with our stakeholders on an ongoing basis. We want to really listen to what our stakeholders are saying in terms of priorities, in terms of additional needs. We meet with folks, especially more than half of the people that we meet with through the year identify as individuals with lived experience, either themselves, meaning they might live with a behavioral health condition, or their loved one, their family member is a person that lives with a behavioral health condition. And of course, it's this serious and persistent mental illness that we're really talking about. And we want to meet with those folks and make sure that we are making sense for those for people. All right. Now I want to talk to you a little bit before I move on about Proposition 1. So the reason that this is important is because should Proposition 1 pass, it will reconstruct the MHSA completely. Right now, at the time of this recording, we don't have an answer as to whether or not the proposition is going to pass. It looks like it will. It is the yes votes right now at the time of this recording are at 50.1% for in support and 49.9% not in support. So we just need a majority vote for it to move forward. And so we've got, a little over 200,000 votes to be counted. We'll know in probably a few more days. But we're making an assumption that it's moving forward, and wanted to make sure that our stakeholders in our community understand kind of what Proposition 1 is and some of the potential impacts on Orange County. So Proposition 1 was placed on the ballot, March 5th ballot that we just all voted in. And really the intention of Prop 1 was a combination of two bills that were passed by the legislature. So there was an Assembly bill and there was a Senate bill. And I'll talk a little bit more about those in detail. But really the combination of these two bills was really to create and focus on 4 strategies to be able to kind of update California's behavioral health system, as well as update the MHSA. So right now, MHSA is geared towards individuals that are living with serious mental illness. Proposition 1, if passed, would expand those target populations to include not just folks living with serious mental illness, but those also with substance use disorder. So really doubling the amount, well, I don't know if double, but expanding the folks that would be eligible for programs and services under this particular fund. The name of the fund would be changed from MHSA, or the Mental Health Services Act, to BHSA, Behavioral Health Services Act. Hence the additional population, not just mental health, right? And really just refocusing what who would be prioritized according to the state for the delivery of the services. So it would be, of course, folks living with serious mental illness, substance use disorder, but also individuals that are at risk of or involved in the justice system. Also, individuals that are homeless or at risk of homelessness, individuals at risk of institutionalization or transitioning maybe out of state hospitals or at risk of conservatorship, conservatees, children and youth that are involved in either the justice system or the child welfare system or at risk of those things. Those would kind of be where the priority populations would be shifted to. Currently, the language in MHSA prioritize individuals that are unserved, underserved populations. And so really looking at those social determinants of health. Prop 1 also focuses on accountability, so some outcomes and transparency. So it would not just be an MHSA plan any longer. It would be a BHSA integrated plan, which means that every single program, every single dollar that goes through public specialty mental health plans would be available in a plan that would be publicly published. This has not been done anywhere else. It's not required of other systems. It's something that will be unique for behavioral health services across the counties, and a very high degree of transparency and accountability. And additional investments in behavioral health housing and really behavioral health treatment. I'll get a little bit more detail of that in the next few slides. And then being able to create a statewide workforce initiative. So what will happen if Prop 1 passes is right now about 95% of the funding that is generated through the millionaire's tax, all the money is gathered up at the state. The state takes 5% of that funding off the top for administrative pieces, and then the 95% is distributed to counties. So each county comes up with their individual plan, and they implement services according to individual need. And with Proposition 1, that amount that is taken off of the top will double. So it'll go from 95% distributed to counties to 90% distributed to counties. And they'll make some additional, the state is wanting to make some additional investments in some workforce initiatives. And they want to take some of our local prevention dollars and instead of doing the prevention pieces at the local level, instead move that up to the state, the California Department of Public Health for implementation of prevention services. So preliminarily, the anticipated impact of the passage of Prop 1 would be really an impact of about over $100 million will be kind of redistributed. And so across our continuum of care. So it will impact our communities with the passage of Proposition 1. Again, should it pass, we'll find out. Senate Bill 326 was the first piece of Proposition 1. And so SB 326 is really talking about the reform of MHSA, updating it in those ways that I had talked about already in terms of increased accountability. AB 531 places a $6.4 billion general obligation bond on the ballot. That's what we voted for, along with updating and changing the intention of MHSA. But this is the other half of it, and it takes about 70% or $4.4 billion for grants to public or private entities for behavioral health treatment in residential settings. So 70% of the bond is to build treatment, locked and unlocked facilities. And then 1.5 billion of that goes to local governments. We're not quite sure if that would come out through an allocation, meaning that the state would just send money to counties, or if it would be a competitive grant. And then $30 million would go to tribal entities. And then $2 billion, or about 30%, would go towards permanent supportive housing, with part of it going for veterans and then the other going for persons that are experiencing or at risk of homelessness that are living with serious behavioral health challenges. So about $1 billion is set aside for veterans housing and $922 million is set aside for other folks. This is just a breakdown of what happens with SB 326 and AB 531, kind of in a side-by-side format. So I went over the 5 different components for MHSA earlier on. Remember CSS, PEI, innovation, capital facilities and technological needs, workforce education and training. Well, all of that would be reimagined. And instead of having those 5 buckets, we would have 3 buckets of funding. And those 3 buckets of funding would be behavioral health services and support. So about 35% of the funding would go to behavioral health services and supports. 35% would go towards full service partnerships. And so full service partnerships are intensive outpatient treatment programs. We currently have some very successful FSP programs that we were running in Orange County. We actually invest a little bit more than 35%. So we need to make a little bit of adjustments on that. And then 30% would go towards housing interventions. And so in SB 326, those housing interventions are really described as subsidies. And so that just is a fancy way of saying things like we would be able to pay for a portion of people's rent, or if they were in a residential treatment facility and couldn't generate enough revenue through billing health insurance, that we could patch some of the funding with this category of housing interventions. So I think I talked a little bit about the difference with the state. In terms of the bond, it's really looking at building about 6,800 new beds for people that to receive mental health care or drug and alcohol treatment at any one time. So that's across the state. And then about 4,300 housing units for homeless individuals, which about 2,300 of those would be set aside for veterans. And so the bond would provide housing to approximately 20% of the veterans experiencing homelessness across the state right now. All right, this is just another way to look at how that changes. So we've got on the left-hand side of the screen, the current model, the different funding ratios and the flexibility. Half of that 76% that you see, that dark blue, The majority of that, it's about 53% in Orange County, goes towards full service partnerships. So it would then take those 5 components of funding and then reimagine them into this other proposed model under BHSA. So right now, in terms of our impact, we're estimating a little bit over 173 million, just based on what we're seeing from the Department of Finance, would be available for BHSA funds beginning in 26-27, which is when this would become effective. So fiscal year, we're bureaucrats. So that means July 1st of 2026 would be the first year that the BHSA integrated plan would be approved. And so with that amount of funding, we would see some impacts. You know, that 100 million is we would redirect some of, we would lose a little bit off of the top as the money is that 5% additional 5% is taken off to go ahead and pay for prevention services. There would not be any preventative services able to be delivered at the local level under the BHSA model. Our continuum of care would start at early intervention and then move its way up and through acuity. We would have programs and services for substance use disorder. That's what SUD is, substance use disorder clients. It will, redirect some mental health treatment funds towards individuals living with substance use disorder. We're not going to be getting any additional funds to expand and treat this additional population. And so we are anticipating significant local impacts on our prevention and early intervention, our CSS general system development funding. And so, like I said, we have that majority of the CSS funding that goes towards full service partnerships. Well, the other piece of that CSS funding is general system development. And so we'll have an impact on that, as well as our workforce education training, capital facilities, and technological needs. And then innovation will not be a standalone category in BHSA. So the innovation component would be essentially eliminated. So prevention at the end and then innovation in the middle. So right now, as we are moving forward with our MHSA plan, just remember we are required to use the funding that we have now and that we will receive in the next year or so as MHSA plans. So we have to use it according to the planned use that's in that 3-year plan. This is just another way to kind of take a look at how we would break up that funding. And so for housing interventions, we would have to invest about $52 million towards housing. We currently invest money towards housing, and we do some subsidies. So we do bridge housing, we do shelter beds, we provide permanent supportive housing. We've got about a little over 300 housing units queued up and being built right now. We're always trying to make sure that we're meeting our housing needs. And so right now, we spend about $24 million a year-ish, right around in there, towards housing. BHSA would have us invest an additional $27.6 million. And so that 27.6 would be coming out of the other existing pots of funding that we would have in MHSA. So out of CSS and PEI, we would then redistribute that into those housing subsidies. The full service partnership, we currently invest about $60.8 million in FSPs. About $99 million in FSPs, and we would have to look at that at $60.8 million towards full service partnership. So it is a difference of about $35.5 million difference. We're hoping that we could generate additional revenue, figure out some creative ways to maximize our billing so that we could bring more money in to make those services and programs whole. The largest impact is going to be on our behavioral health services and supports. We would have about $60.8 million available in that bucket as well. Currently, if we took all of our existing programs that would fit into the BHSS bucket, that is about $217 million. And so that is a difference of about $156 million difference. So it's going to have a definitive impact. We're also experiencing not just the change in Prop 1, but we're actually seeing a decrease in our revenue. So the actual MHSA fund has been decreasing. And so we are not getting as much money as we had typically in the past. And so that's having kind of an additional impact to Proposition 1. So I don't want you to think it's all Proposition 1 doing this. It's definitely because we have decreased amount of money that we're going to be receiving from the state. Oh, that's really difficult to see, but this is just really showing kind of the ability, like we have to continue with our MHSA plan while we start thinking about our Behavioral Health Services Act integrated plan at the same time. So we're going to be doing some pretty intensive community program planning as all of this moves forward. So as you can see, because all of this changed, because here we are in our process, we have to go through a 30-day public comment and posting. We have to do a public hearing. There's all of these requirements for MHSA for us to spend the money. And in order for us to meet our timelines, we have to do this now before we have an answer about how things are going to be moving forward for our MHSA plan. So with that said, you are not going to see a whole lot of changes. We do know, again, that we have to right-size some of our programs because we're not going to have as much revenue. So we are looking at reducing some funding in prevention and early intervention, community services and supports. We want to pull down any innovation dollars that we are expecting to be able to spend at the state. So you'll see a big, huge increase in innovation. And then a little bit of a reduction in workforce education and training, and a little bit of increase in capital facilities and technological needs as we try to expand the county footprint into the South County region when we build an additional site to be able to invest in and provide additional services there. Okay, so talking a little bit about prevention and early intervention. PEI is actually not just prevention and early intervention. The state, several years back, updated those regulations and created kind of these state-defined programs. Outreach for increasing recognition of signs and symptoms of mental illness, stigma and discrimination reduction, prevention, suicide prevention, access and linkage to treatment, and early intervention. So we're required to spend money in each one of those state-defined programs. The way that we do this is demonstrated here on the slide. So we have all of our different PEI programs kind of delineated into each of those particular programs. You can pause if you'd like this part of the recording and take a look at those. I'm going to go through so for the sake of time. And so for prevention and early intervention, we're making some updates right now. We're right-sizing programs. And then what that means is we're looking at how much money did you spend in the last year or so, and then we're adjusting our budget according to that. And usually we do that on a regular basis. And then if we see there's a unspent pot of funding, we will reinvest it into those PEI component programs. But because we know that we're going to be receiving less money, we're not going to reinvest it. We're going to take it as kind of like a reduction. So that is what that looks like. For community services and supports, exact same logic. CSS contains 21 programs. So it's really for our crisis system of care, our full service partnerships, housing, homeless services, outpatient clinical expansion. So just being able to provide additional care to folks that might need a specialty level of care within an outpatient kind of clinical setting. Outreach, engagement, and access, and then peer and family support section. So this is what that looks like in terms of being able to reduce our budget to meet the actual revenue that we're going to be receiving. And we spend to the top of our budget in Orange County. So that means when this is a very volatile revenue stream. So it means that we get big, huge amounts of money, and then we get really small amounts of money. And so being able to kind of manage that is a challenge. And because we do budget to the top of that budget, sometimes we need to make these adjustments. So you can pause and take a look at that if you like. For innovation, this is where you're going to see the biggest, the significant change. We would like to create some additional innovation projects. Right now, we've got an approved community planning project under innovation. We want to add some additional dollars to that because we want to be as innovative as possible when we're looking at how do we plan for our system of care, how do we do some of this community program planning in a very innovative way. And then we are looking at starting a multi-component project that is called Progressive Improvements of Valued Treatment, or PIVOT, as we have to change our entire system and redesign it with MHSA. We want to look at some of the things that we know we might need to do better in our system. And so we're looking at about a $35 million budget for a multi-component project. And then we have been doing the Psychiatric Advanced Directive program. It's a statewide program. We're establishing a cloud-based pad that functions in a very similar way to maybe a social media site, except for a very secured social media site, where folks, if they are experiencing a psychiatric crisis, would be able to share their pads, and it has the information in there in terms of, this is how I would like you to treat me, and these are my wishes during a psychiatric crisis, similar to how a healthcare directive would be for a physical healthcare condition. All right. So the Progressive Improvements of Value Treatment, or PIVOT program, would really look at 5 different components. So innovative approaches for delivery of care. So looking at right now, what do our clinics look like right now? And are they really set up for all of these changes in policy that are happening at the state level right now? We're seeing a complete redesign of the Medi-Cal system. We're seeing MHSA change. And so we want to be able to really think about what that clinical design should look like. Then we want to do a full service partnership reboot, testing a social finance approach to improve client outcomes. Right now, it's bill, which is super important. But sometimes if you're focused on billing, you need to be focusing on how making people better. And so we want to be able to combine those two and test that out through a social finance approach. We also are looking at integrated complex care management, so testing whole person approaches for care in older adults with comorbid conditions, and then developing capacity for specialty mental health plan services in diverse communities. Sometimes folks don't want to go to a mental health clinic, or they feel more comfortable in a community-based organization that has folks that look like them, that are from the same culture or orientation from them as them. And so they feel more comfortable getting services there. And so we have a lot of those community-based organizations in our community, but they're not specialty mental health providers. So our idea and thought is, what does it take to do that? How can we help provide technical assistance? What kind of capacity does somebody need to have in order to become Medi-Cal certified, to be able to deliver those services? It's a very high standard of care to be able to provide specialty mental health plan behavioral health services. And so we're kind of want to work with those community organizations to be able to help figure out exactly how to do that and support those folks so that we can do even better in our communities. And then really looking at an innovative county-wide workforce initiative. We know that we have a behavioral health workforce shortage, and there are successful ways. We have some internship programs, like some residency, but there are other systems that use things like apprenticeship programs to build their workforce. And it comes with additional incentives and pay. And so being able to attest in that way, that's something that we're thinking of exploring. So that will be definitely a change in the plan. And there, you will find that in the new section, the new programs section. We actually will be building out the innovation component program and project for additional information, and that will be like a whole separate plan that'll be posted. But we wanted to at least get the concepts out there to see how people respond. All right, so for workforce education and training, we're looking at just kind of right-sizing some of those projects, hoping that we get our innovative workforce initiative up and running so we can look at other innovative ways to be able to incentivize the recruitment and retention of our staff as well as their development. And then for capital facilities and technological needs, there's the Be Well Irvine campus. That's why we will see an increase of about $10 million to be able to invest in that campus. So again, feel free to pause during any of these if you want to take a better look at any of those budget sections. Alrighty, so next steps, we are required to have our MHSA annual update approved by the Board of Supervisors before June 30th, 2024. Or actually, it's before July 1st, but June 30th, 2024. We're going to be moving our component programs forward. We're going to be looking at the new and expanded innovation concepts. We are in the middle of our 30-day review and public comment session right now. So we will have the plan posted by April 15th, 2024. So we're hosting a series of meetings. We're going to post this video up. So if folks can't attend the meeting, they can always get the information. We are set to review the public comments with our Behavioral Health Advisory Board on April 17th. And then the Behavioral Health Advisory Board will host a public hearing on April 24th at the Westminster Community Center from 10 a.m. to 12 p.m. Once we are, fingers crossed, everything goes well at that public hearing, then we will present the plan to the Board of Supervisors either in May or June. We're shooting for the end of May for their approval, and then we will submit the plan to the Department of Healthcare Services and the Mental Health Services Oversight and Accountability Commission. So if you would like to review and have access to the plan, pick up your phone, scan that QR code. I promise it's legit. It's not anything that will do anything bad to you, but you can access the draft plan that way, or you can put in the link. You can also, if you want hard copies of the plan, you can go ahead and call the MHSA office at 714-834-3104, or send us an email at mhsa@ochca.com. And we are happy to send you any of that information to meet with you. If you'd like to have an individual meeting with any of us, again, send us an email, give us a call. We can set that up. We are taking comments all throughout this planning period, and then we can even take comments afterwards. They just won't be part of the official 30-day public comment period. All right. If you have any questions, again, Michelle Smith, that is my direct email, as well as the phone number. And if you get a chance to provide a public comment, we would very much appreciate it. And thank you so much for listening to the presentation for today. Appreciate all of your time and hope to see you soon. Thank you.